Yeah, I don't. You can write them down, and I think you can email them directly to Mitsuru. I don't know what else to say. All right, so we will move right to the next session. We don't have a break, sorry, but if you need to take a break, feel free to sneak out quickly. Adrienne is unable to be with us. She had a family emergency, so Fariba will be taking over the second session, but for now it's Lisa.
Thank you. Okay, our first presenter of this session is Janis Blair, who needs no real introduction to this group. And she's going to speak about testing for Coccidioidomycosis in hospitalized patients with pneumonia within the Coccidioides-Endemic area. Janis.
Thank you. So I want to start off by thanking the organizers for the invitation to do this on behalf of myself and my colleague Gretchen Taylor from Hospital Internal Medicine. By way of background, there's now been several studies that have looked at what the percentage of cocci is the etiology for community-acquired pneumonia in both Arizona and Southern California. And recently, Dr. Galgiani has done a whole lot of work looking at getting increased testing rates, especially in urgent cares and in emergency department work, and has really shown very nicely that not only is it variable in testing, but the results in the percent positive is variable over time. So we also have been working on cocci testing in outpatient community-acquired pneumonia, and we're continuing to work on that. But we don't know the rate of cocci testing among inpatients with community-acquired pneumonia. And you might say, well, of course we do. Well, we don't really. This is going to be a sicker subset of the types of patients we've looked at more carefully. So our aim was to assess the frequency of cocci testing among hospitalized patients with pneumonia at Mayo Clinic Hospital in Arizona, just a couple blocks down the road. And we first wanted to calculate the percent of patients who were getting cocci testing, and then to understand whether positive serologic testing would lead to a reduction in the antibacterial antibiotic use, so a form of stewardship, if you would. One would think if someone has cocci, then maybe the antibiotics would go down. So we commissioned an electronic tool by our information technology to query our EPIC patients. We did create the list of all Mayo Clinic Hospital inpatients with pneumonia. We did use J18 through J18.9, but if you look at all the codes, it's all J18.9 anyway, which is unspecified pneumonia. And we listed which team ordered and what the result of the serology was, which methodology they used, and then the results. We just said either positive or negative. We identified indeterminate to be negative. If it was reactive, we called it positive. And then we also just collected the names and dates of antibacterial, antifungals, and the dates that they were started. So in calendar year 2024, the hospital internal medicine patients with pneumonia, there was 1,162, and 66% were tested for cocci. 11% of those overall were seropositive. 391 were not tested, and potentially, if it was the same rate of positivity, we would have missed 43 patients with cocci. So the mean time from admission to the test order was half a day, which for most people means that they were tested on the day of admission, and then the mean time from admission to results was 3 days. Among the 87 positives, the duration of antibacterials was 4.2 days, and compared with the ones who were negative or not tested, the duration was 4.1 days. And 63% of the positives did receive antifungals in the hospital, and the remainder received antifungals after discharge. We did note that empiric antifungal treatment, all of it being fluconazole, was performed in 15% of the patients we looked at. And of those, 1/3 had positive serology. So in the spirit of trying to be channeled Dr. Galgiani, I did map out the number of hospital internal medicine, community-acquired pneumonia, that's in the dark blue, that's the numbers for the month, and went through the months, and then the number of valley fever tested in orange bar. The proportion of valley fever tested in the green line at the top, and the proportion of test positivity did vary by month in the blue running line. So overall, we had 66% tested, and the month testing ranging from 59 to 73, and 11% overall test positivity, with 3% identified in March and up to 19% positive in December. So limitations, for those of you who aren't familiar with billing codes, do you think, why in the world is this a limitation? I've heard this limitation now at least 4 or 5 times this meeting. The problem is this is somebody thought they had pneumonia. It doesn't mean they did have pneumonia. It doesn't mean it was the discharge diagnosis. So this could be, somebody could have said at admission, I think this is pneumonia, and then you find out that it's a pleural effusion, or you find out it was cancer, or you find out it was something else, but they still had been coded for pneumonia. So it's not necessarily pneumonias, and I'm strongly hoping not to do a chart review. So I'm going to just leave this as a limitation. We only included people on the hospital internal medicine service. So I did collect the data on critical care and cardiology and all the other non-medicine hospital services, and I will go back and look at those. In addition, we only looked at serology. We didn't look at culture, PCR, pathology results. We didn't look for alternate causes of pneumonia. So somebody might have come in, had a COVID positive, or had influenza positive, and then the team might have thought, well, that's the cause of the pneumonia as well. So we're going to look at other possible causes and go from there. So the next steps, and we will refine that tool. We'll go back and look at what's happening in critical care, and we already provided feedback to the hospital internal medicine physicians and the trickle down to residents, nurse practitioners, and physician assistants, and we'll monitor over time. So I think what we found is cocci is still an important cause of pneumonia within the inpatient setting in southern Arizona. 1/3 of the patients in our practice were not tested, and this, of course, becomes an opportunity to figure out what are the barriers to testing. And interestingly, the positive tests were not associated with stopping antibacterials. So I thought, well, maybe this is the turnaround time, which is actually pretty fast. But my colleague and co-author said, there is no way that I'm going to stop antibiotics for EIA IgM only. I'm like, okay, well, there you go. And so we'll have to look back at some of those, and as they continue to serial convert, provide that feedback, and maybe they will feel more comfortable with that. And really, according to my colleagues, it's like, yeah, we're not stopping antibiotics. So there's some opportunities there. So with that, any questions?
Janis, great. One thing you could look at was something that we noticed was that patients were admitted to the hospital, not because they were really that sick, but because they'd been sick without a diagnosis. It's an outpatient, so we got to get them in the hospital. And then they get a cocci serology ordered, and it's positive, and they're discharged quickly with a median time of less than 3 days. So you might look at that as an outcome. of those who get a diagnosis of cocci, whether it shortens the length of stay.
Excellent, thank you.
Dr. Blair, that was an excellent presentation. Thank you for sharing those data. Couple questions. One is, first of all, I just want to compliment you. 66% of pneumonia patients being tested. You make it sound like that's a deficiency, but that is the highest number that we have ever heard anywhere, ever. So just take that in.
I thought it was going to be 100%.
Well, I know it's Mayo, but still 66% is phenomenal. Are you able to look at, and I was just talking to John about this, I want to answer this question everywhere. Are you able to look at among those who were tested for cocci, comparing those who had cocci and those who didn't have cocci, and look at the characteristics of those who ended up with cocci so that we can better guide people on who to test in the future?
I can do that. Yes, I think that's a great suggestion. Although it might make me go back to the chart.
Sorry. Maybe we can help you with that. And then my last question, and I actually wanted to ask the CDC folks this, but when we talk about the limitations of ICD-10 codes, which we talk about it all the time in public health, did you use just the primary diagnosis or did you use primary and secondary together?
Yeah, we were using if it was both primary and secondary.
Okay, and that's typically what I found covers everything, but it's almost like you could do a sensitivity analysis using just primary and then one of any. But I loved what you presented.
Yeah, I might put that into our tool so I don't have to go to the chart for that.
So Janice, it won't surprise you that I'm going to take away all the praise that Rebecca heaped on you.
That doesn't
Because as you and
surprise
I
me.
know, we thought at Mayo Clinic, 100% of hospitalized patients would get a cocci serology. And so this is part of a group effort Janice is doing and Justin is doing down at UMC Tucson and also Jonas Marshall. And Justin, you found almost similar data. So what we thought, there are a couple of ideas here. First of all, patients that we would think slam dunk should be tested for a pneumonia, and with all the caveats about coding, it's not happening. But the second part is we can use stewardship, and that was the idea of this, using hospital stewardship programs, because we don't do hospital stewardship. We could, but it has not been something we've looked at, and it's particularly important. What's unique about cocci among the dimorphics, it causes a very high rate of primary pneumonia. That's very different than histo and blasto. That's what makes all our practices so difficult. Cocci is different. So the work will continue, and these are great questions, so that we can get these rates up. And also, I think that's a great point, Rebecca, to look more deeply about how we can distinguish these. Because I think even you, Justin, it's been hard to figure out those who are positive, what effect that has. But it hasn't shortened antibiotics. And we'll look at how long they stay in-house. So anyway, thank you.
Thank you very much, Janice. Great talk. Okay.